Welcome to the deep dive. We're going to be taking a deep dive specifically tailored for you. You're a nurse and a student navigating the demanding world of healthcare. So we're going to delve into a system that you're intimately familiar with, the sympathetic nervous system, or SNS. You experience its effects every day, whether it's that jolt of adrenaline in a stressful situation or the subtle ways it keeps your body running smoothly.
The SNS is behind our fight or flight response, that primal instinct that kicks in when we face danger. But it's much more than just an emergency system. It plays a vital role in regulating countless bodily functions from heart rate and blood pressure to digestion and temperature control.
And today, we're focusing on the drugs that interact with this powerful system. Adrenergic agonists, also known as sympathometics. These medications mimic the actions of the SNS, and they're essential tools in your nursing arsenal. In this deep dive, we'll unpack how they work at the molecular level, explore their various uses, discuss potential side effects, and most importantly, equip you with the knowledge to provide top-notch care to your patients taking these medications.
It's about moving beyond rote memorization and developing a deeper understanding of these drugs, how they interact with different receptors, their diverse effects on the body, and the nuances of their administration.
Okay, so let's lay the groundwork. Can you give us a quick overview of the nervous system, that intricate network that governs everything we do?
Imagine the nervous system as the body's control center. It's a vast communication network that receives input, processes information, and sends out commands to every corner of the body. This intricate system is broadly divided into two main branches: the central nervous system, comprising the brain and spinal cord, and the peripheral nervous system, which extends outward, connecting the central nervous system to the rest of the body.
And within the peripheral nervous system, we have the autonomic nervous system, the unsung hero that regulates involuntary functions. Those things we don't consciously control, like breathing, digestion, and yes, our fight or flight response.
The autonomic nervous system is the silent workhorse keeping our internal environment in balance, a state we call homeostasis. And within this system, we have two key divisions: the sympathetic nervous system, which we're focusing on today, and the parasympathetic nervous system. They act like a carefully choreographed dance, constantly adjusting and counterbalancing each other to maintain equilibrium.
So the sympathetic nervous system ramps us up for action, while the parasympathetic system calms things down. It's that age-old dance between fight or flight and rest and digest.
Now let's zoom in on the sympathetic nervous system and how it orchestrates this intricate response. Imagine a network of specialized nerve cells or neurons transmitting messages throughout the body. These messages are carried by chemical messengers called neurotransmitters, which act like keys that fit into specific locks called receptors on target cells.
And the primary neurotransmitters in the sympathetic nervous system are epinephrine, norepinephrine, and dopamine, right? I've encountered these names countless times in my nursing practice.
These three neurotransmitters, collectively known as catecholamines, are the key players in the fight or flight response. They bind to specific receptors, aptly named adrenergic receptors, triggering a cascade of events that prepare the body for action.
Adrenergic receptors, got it. Now, can you tell us more about these receptors? Are they all the same, or do they have different subtypes and functions?
That's a great question. It's crucial to understand that adrenergic receptors are not a monolithic entity. They come in different subtypes, each with its own unique function and distribution throughout the body. This is where the complexity and specificity of the sympathetic nervous system truly shine.
Okay, so this is where it gets really interesting. So let's talk about those different subtypes of adrenergic receptors.
Certainly. Let's start with the alpha adrenergic receptors, which are further subdivided into alpha 1 and alpha 2 receptors. Alpha 1 receptors, primarily located on smooth muscle cells in blood vessels, are responsible for vasoconstriction, the narrowing of blood vessels, which increases blood pressure.
So that's how medications like phenylephrine, our go-to nasal decongestant, work. By stimulating alpha-1 receptors in the blood vessels of the nasal passages, constricting those vessels and reducing swelling. It's like shrinking those engorged blood vessels to open up the airways.
Now moving on to alpha 2 receptors. These receptors, found on presynaptic neurons, act as a sort of feedback mechanism, inhibiting the release of norepinephrine, thus modulating sympathetic activity. They play a role in regulating blood pressure, pain perception, and other functions.
Fascinating. So alpha-2 receptors are like the brakes, preventing the sympathetic nervous system from going into overdrive. It's a beautiful system of checks and balances.
Now let's move on to the beta-adrenergic receptors. These receptors are further subdivided into beta-1, beta-2, and beta-3 receptors. Beta-1 receptors, primarily located in the heart, are responsible for increasing heart rate and contractility, the force of the heart's contractions.
So medications like dobutamine, often used in heart failure, work by stimulating beta-1 receptors, giving the heart a boost to pump more effectively.
Moving on to beta-2 receptors. These receptors, found predominantly in the lungs, are responsible for bronchodilation, the relaxation of the airways, which makes breathing easier. That's why beta-2 agonists like albuterol are the cornerstone of asthma treatment, opening up those constricted airways and allowing for smoother airflow.
And beta-3 receptors, I recall those being involved in the relaxation of smooth muscle in the bladder, leading to increased bladder capacity. That's how mirabegron, a newer medication for overactive bladder, works its magic, right?
Mirabegron selectively targets beta-3 receptors, providing a targeted approach to managing overactive bladder symptoms.
This is all starting to make so much sense. It's like a complex puzzle, but we're slowly piecing it together, understanding how each receptor subtype plays its unique role.
And this understanding is the foundation for mastering the use of adrenergic agonists in clinical practice. It allows you to not just know what these drugs do, but why they do it and how they can be harnessed to benefit your patients.
Now, let's talk about the stars of the show. The adrenergic agonists, also known as sympathomimetics. These medications essentially mimic the actions of the sympathetic nervous system, right?
Adrenergic agonists are a diverse group of medications that stimulate and mimic the actions of the sympathetic nervous system. They work by binding to adrenergic receptors, triggering the same downstream effects as the naturally occurring neurotransmitters epinephrine, norepinephrine, and dopamine.
So they're like master impersonators fooling the body into thinking it's receiving signals from its own nervous system.
And this mimicry allows us to manipulate the sympathetic nervous system in a targeted way, achieving therapeutic effects in a wide range of conditions.
And these medications achieve their mimicry in two different ways, right?
Yes. Some adrenergic drugs, like epinephrine, act directly on the receptors, binding to them just like the natural neurotransmitters do. These are called direct-acting sympathomimetics.
So they're like a key that fits directly into the lock, triggering an immediate response.
Other adrenergic drugs, like amphetamine, work indirectly by increasing the release of stored neurotransmitters from nerve terminals. These released neurotransmitters then go on to activate the receptors, producing the desired effect. These are called indirect-acting sympathomimetics.
So they're like a key maker, producing more keys to unlock those receptors.
And finally, we have mixed-acting sympathomimetics, like ephedrine, which do a bit of both. They bind directly to the receptors and also trigger the release of stored neurotransmitters.
So they're like a combination key and key maker covering all the bases. Now, I understand these medications are categorized into different classes based on their therapeutic uses. Can you walk us through some of these key categories?
Let's start with a group you're undoubtedly familiar with, bronchodilators. These medications, primarily beta-2 agonists, are the mainstay of treatment for conditions like asthma and chronic obstructive pulmonary disease, or COPD. They work by relaxing the smooth muscles surrounding the airways, opening up those constricted passages and allowing for easier breathing.
Ah, yes, the trusty inhalers that provide such quick relief to patients struggling to breathe. I remember the first time I administered albuterol to a patient in respiratory distress. It was like witnessing a miracle, seeing their breathing ease and the panic in their eyes subside.
Albuterol is indeed a classic example of a short-acting beta-2 agonist, providing rapid relief during acute episodes. Then we have long-acting beta-2 agonists like salmeterol, which are used for long-term control and prevention of symptoms. They're like the maintenance crew, keeping those airways open and preventing those episodes from occurring in the first place.
And it's crucial for patients to understand the difference between these two types of inhalers, knowing when to reach for their rescue inhaler versus taking their daily maintenance medication.
Now, moving on to another common category of adrenergic agonists, nasal decongestants. These medications, primarily alpha-1 agonists, work by constricting the blood vessels in the nasal passages, reducing swelling and congestion.
Think phenylephrine, the go-to remedy for a stuffy nose. It's like shrinking those swollen blood vessels, opening up the nasal passages and allowing for clear breathing.
Phenylephrine, oxymetazoline, and pseudoephedrine are common nasal decongestants, providing relief from that that stuffy, congested feeling. However, it's important to note that they only address the symptom, not the underlying cause of the congestion.
And overuse of nasal decongestants can actually lead to rebound congestion, making the problem worse in the long run. It's like a vicious cycle where the temporary relief creates a dependence on the medication, leading to more congestion when it wears off.
It's crucial to counsel patients on the appropriate use of these medications, emphasizing that they are for short-term relief and should not be used for extended periods. Now, shifting gears to a specialized category. Ophthalmic agents. These adrenergic agonists, also primarily alpha-1 agonists, are used in ophthalmology for various purposes, from dilating the pupils for eye exams to reducing intraocular pressure in glaucoma.
So they're like precision tools targeting specific structures in the eye to achieve desired effects.
And finally, we come to the most critical category for our deep dive today, vasoactive agents. These medications have a profound impact on the cardiovascular system and are often used in critical care settings to support patients with heart failure or shock.
Now, this is where the real power of adrenergic agonists comes into play, directly influencing the heart and blood vessels.
Vasoactive adrenergic agonists encompass a wide range of medications, each with its own unique receptor affinity and clinical application. They're powerful tools that require a deep understanding of their pharmacology and potential side effects.
Before we delve into the specifics of vasoactive agents, which we'll cover in detail later, let's take a step back and revisit some key terms and concepts to ensure a solid foundation for our further exploration.
That's an excellent idea. Let's solidify our understanding before moving on to the more intricate aspects of this topic.
So starting with catecholamines, those essential neurotransmitters we discussed earlier, can you remind us of their significance in the context of the sympathetic nervous system?
Catecholamines, as we mentioned, are naturally occurring substances that act as neurotransmitters in the sympathetic nervous system. They're responsible for mediating the fight or flight response, that primal instinct that prepares us to deal with danger.
And the three main catecholamines are epinephrine, norepinephrine, and dopamine, right? I always found it fascinating how these three seemingly simple molecules can orchestrate such a complex and powerful response.
Their actions are far-reaching and intricately interwoven, influencing various bodily functions from heart rate and blood pressure to respiration and metabolism.
And butamine, a synthetic catecholamine, acts primarily on beta-1 receptors in the heart, mimicking the effects of epinephrine and norepinephrine.
Dobutamine is a valuable tool in managing heart failure, providing inotropic support, meaning it increases the force of the heart's contractions.
Now, moving on to those fascinating adrenergic receptors, can you give us a quick recap of their different subtypes and their respective functions?
Adrenergic receptors, as we discussed, are those specialized proteins on the surface of cells that bind to catecholamines, triggering a cascade of events that ultimately lead to the characteristic effects of the sympathetic nervous system.
And these receptors are classified into two main types, alpha and beta, each with their own subtypes and specific functions.
Alpha receptors are further divided into alpha-1 and alpha-2 receptors, while beta receptors are classified into beta-1, beta-2, and beta-3 receptors. Alpha-1 receptors, as we discussed, are primarily involved in vasoconstriction, while alpha-2 receptors act as a feedback mechanism modulating sympathetic activity. Beta-1 receptors primarily affect the heart, increasing heart rate and contractility, while beta-2 receptors relax bronchial smooth muscle, opening up the airways. Beta-3 receptors are involved in the relaxation of smooth muscle in the bladder, leading to increased bladder capacity.
It's incredible how such a seemingly simple system can have such diverse and profound effects on the body.
It is indeed a testament to the elegance and complexity of human physiology.
Now, let's shift our focus to the mechanisms of action of adrenergic agonists. We've touched upon this earlier, but can you elaborate on the different ways these medications achieve their effects?
Adrenergic agonists, as we've discussed, are medications that mimic the actions of the sympathetic nervous system by binding to adrenergic receptors. They achieve this mimicry through three main mechanisms: direct acting, indirect acting, and mixed acting.
Direct-acting agonists like epinephrine bind directly to the receptors, triggering an immediate response. So it's like a key fitting perfectly into a lock, unlocking the door to a specific cellular action.
Indirect acting agonists, like amphetamine, work by increasing the release of stored neurotransmitters from nerve terminals, which then go on to activate the receptors. It's like adding more fuel to the fire, amplifying the signal, and producing a more sustained effect.
And mixed-acting agonists like ephedrine do a bit of both, binding directly to the receptors and also enhancing neurotransmitter release. They're like a versatile key that can unlock the door and also boost the signal strength.
Understanding these different mechanisms of action is crucial because it influences the onset, duration, and potential side effects of the medication. It it allows you to choose the right tool for the job, tailoring your approach to the specific needs of your patient.
This is all starting to come together beautifully. It's like a symphony of interconnected concepts, each playing its part in the grand orchestration of the sympathetic nervous system.
It is indeed a fascinating system, and understanding its intricacies is essential for mastering the use of adrenergic agonists in clinical practice.
Now let's delve into the specifics of the different classes of adrenergic agonists and their clinical applications, starting with bronchodilators, those essential medications for respiratory conditions like asthma and COPD.
Bronchodilators are a cornerstone of respiratory care, providing relief to countless individuals struggling with conditions like asthma and COPD. These medications, as we've discussed, primarily target beta-2 adrenergic receptors in the lungs, relaxing the smooth muscle surrounding the airways and allowing for easier breathing.
I can still vividly recall the sense of relief on my patient's face when I first administered albuterol during an acute asthma attack. It was like watching a dark cloud lift, their breathing becoming less labored, their chest no longer heaving with each desperate gasp for air.
Albuterol is indeed a classic example of a short-acting beta-2 agonist providing rapid but transient relief. It's like a quick burst of energy, opening up those airways swiftly, but its effects wear off relatively quickly.
Hence the importance of those long-acting beta-2 agonists for long-term control. They're like the steady hand maintaining airway patency and preventing those acute exacerbations.
Salmeterol, formoterol, and indicatorol are examples of long-acting beta-2 agonists taken regularly to keep those airways open and prevent those sudden, frightening episodes of breathlessness. It's like having a reliable friend always by your side, ensuring you can breathe freely and go about your day without fear of an attack.
And it's crucial for patients to understand the difference between these two types of inhalers, knowing when to reach for their rescue inhaler versus taking their daily maintenance medication. I often use the analogy of a fire extinguisher and a smoke detector. The rescue inhaler is like the fire extinguisher used in emergencies to put out the fire, while the long-acting inhaler is like the smoke detector, constantly vigilant, preventing those fires from starting in the first place.
That's an excellent analogy. It paints a clear picture that patients can easily grasp. Now, shifting our focus to another common application of adrenergic agonists, nasal decongestants. These medications target alpha-1 adrenergic receptors in the blood vessels of the nasal passages, constricting those vessels, reducing swelling, and opening up those congested airways.
Think phenylephrine, a familiar name in over-the-counter cold and allergy remedies. It's like a temporary shrink ray, reducing the size of those swollen blood vessels and allowing air to flow more freely through the nose.
Phenylephrine, oxymetazoline, and pseudoephedrine are common nasal decongestants, providing relief from that stuffy, congested feeling. However, it's important to note that they only address the symptom, not the underlying cause of the congestion.
And overuse of nasal decongestants can actually lead to rebound congestion, making the problem worse in the long run. It's like a vicious cycle where the temporary relief creates a dependence on the medication, leading to more congestion when it wears off.
It's crucial to counsel patients on the appropriate use of these medications, emphasizing that they're for short-term relief and should not be used for extended periods. Now, moving on to a more specialized application of adrenergic agonists, ophthalmic agents. These medications, primarily alpha-1 agonists, are used in ophthalmology for a variety of purposes.
I remember using phenylephrine eye drops to dilate pupils for eye exams. It's fascinating how these medications can target specific structures in the eye, producing such precise effects.
Ophthalmic adrenergic agonists are valuable tools in ophthalmology. Phenylephrine, as you mentioned, is used to dilate pupils, facilitating eye exams. Epreclonidine, another alpha-2 agonist, is used to lower intraocular pressure in glaucoma. And brimonidine, yet another alpha-2 agonist, is used to treat ocular redness. These medications, like skilled artisans, work with precision, targeting specific receptors to achieve the desired outcome.
And now we arrive at the heart of our deep dive, the vasoactive agents. These medications, with their profound effects on the cardiovascular system, are essential tools in critical care settings, often making the difference between life and death for patients in precarious situations.
Vasoactive adrenergic agonists are a powerful force in critical care, wielding influence over heart rate, blood pressure, and blood flow distribution. They're the heavy lifters often called upon in emergencies to support patients with heart failure or shock.
Now, let's take a closer look at some of the key players in this category, starting with dopamine, a fascinating drug with a repertoire of effects depending on the dosage. It's like a chameleon, changing its colors, or rather, its actions based on the concentration used.
Dopamine is indeed a versatile medication. At low doses, it acts primarily on dopamine receptors in the kidneys, increasing renal blood flow and promoting urine output. This effect is particularly beneficial in patients with acute kidney injury or those at risk of developing kidney damage.
So it's like a gentle nudge encouraging those kidneys to keep filtering and maintain fluid balance.
As we increase the dose, dopamine starts to exert its effects on beta-1 receptors in the heart, increasing heart rate and contractility, supporting cardiac output. It's like stepping on the gas pedal, providing a boost to the heart's pumping action.
And at even higher doses, dopamine activates alpha-1 receptors, leading to vasoconstriction and an increase in blood pressure.
It's like tightening the belt, constricting those blood vessels and raising blood pressure, often a life-saving measure in shock or severe hypotension. However, it's crucial to note that dopamine is contraindicated in patients with pheochromocytoma, a type of tumor that secretes catecholamines as it can exacerbate hypertension.
Now let's talk about another workhorse in critical care, norepinephrine, often the first-line agent in septic shock.
Norepinephrine, also known as Levophed, is a potent vasoconstrictor primarily stimulating alpha-1 receptors. It's like the emergency brake, clamping down on those blood vessels, raising blood pressure swiftly and effectively.
And unlike dopamine, norepinephrine has minimal effects on beta-1 receptors, so its impact on heart rate is less pronounced.
Norepinephrine is a valuable tool in situations where blood pressure needs to be raised quickly and effectively without significantly affecting heart rate.
Now, what about epinephrine, that adrenaline rush we all know and love? Or perhaps fear, depending on the circumstances. It's like the ultimate first responder, always ready to jump into action in emergencies.
Epinephrine is indeed the go-to medication for anaphylaxis and cardiac arrest, situations where every second counts. It's a non-selective adrenergic agonist, meaning it stimulates both alpha and beta receptors, producing a wide range of effects.
So it's like a multi-tool equipped to tackle multiple challenges simultaneously, raising blood pressure, increasing heart rate, and opening up those constricted airways, all in a rapid and coordinated effort.
Epinephrine is indeed a remarkable medication, a testament to our ability to harness the power of the sympathetic nervous system for therapeutic benefit.
Now, shifting gears to dobutamine, our beta-1 agonist friend that we mentioned earlier, it's like a specialized mechanic focusing solely on improving the heart's pumping action.
Dobutamine is a valuable tool in managing heart failure, providing inotropic support, meaning it increases the force of the heart's contractions, improving cardiac output, and alleviating symptoms of heart failure.
And unlike dopamine, dobutamine has minimal effects on blood pressure, making it a safer option for patients with borderline hypertension.
Dobutamine is often preferred in situations where we want to enhance cardiac output without significantly impacting blood pressure. It's like fine-tuning the engine, optimizing its performance without overloading the system.
Now, let's touch on a couple of other vasoactive adrenergic agonists that, while less commonly used, have their unique niches in clinical practice. First up, phenylephrine, which we've encountered before in the context of nasal decongestants and ophthalmic agents. But it also has applications in managing hypotension and shock.
Phenylephrine, in its injectable form, is primarily an alpha-1 agonist causing vasoconstriction and raising blood pressure. It's often used in situations where a rapid and short-lived increase in blood pressure is desired.
So it's like a quick fix, providing a temporary boost to blood pressure until more definitive measures can be taken.
And lastly, we have midodrine, a prodrug that's converted to its active form, disglymidodraine, in the body. Disglymidodraine is an alpha-1 agonist causing vasoconstriction and raising blood pressure. It's primarily used to treat orthostatic hypotension, a condition where blood pressure drops significantly upon standing.
So it's like a supportive friend, helping those with orthostatic hypotension to stand tall without feeling faint or dizzy.
Midodrine is a valuable option for managing orthostatic hypotension, improving quality of life for individuals who struggle with this condition.
Now that we've explored the diverse world of adrenergic agonists, let's shift our focus to the potential adverse effects and toxicity associated with these medications. They're powerful tools, and with great power comes great responsibility, as the saying goes.
Understanding the potential adverse effects of adrenergic agonists is crucial for ensuring patient safety. These medications, as we've discussed, mimic the actions of the sympathetic nervous system, so their side effects are often an extension of the fight or flight response.
So it's like pushing the body into overdrive, which can have unintended consequences if not carefully monitored and managed.
One of the most common side effects is central nervous system stimulation, which can manifest as anxiety, restlessness, insomnia, tremors, and even seizures in severe cases. It's like revving the engine too high, pushing the nervous system beyond its comfort zone.
Mm. And cardiovascular effects are another major concern, with tachycardia, palpitations, hypertension, and even arrhythmias being potential complications, especially in patients with pre-existing heart conditions.
It's crucial to monitor cardiac rhythm and blood pressure closely in patients receiving adrenergic agonists, particularly those with underlying cardiovascular disease. It's like keeping a close eye on the gauges, making sure the engine isn't overheating or running out of control.
And we can't forget about other potential side effects like nausea, vomiting, sweating, and muscle cramps, which, while generally less serious, can still impact a patient's quality of life.
Patient comfort and well-being are paramount, and it's essential to address these side effects promptly and effectively. Now let's talk about toxicity, which can occur with excessive doses or in patients who are particularly sensitive to these medications.
Toxicity from adrenergic agonists can be a life-threatening emergency requiring prompt recognition and intervention. It's like a runaway train careening out of control with the potential to cause significant damage.
The symptoms of toxicity often mirror the adverse effects we just discussed, but they are more pronounced and can quickly escalate, leading to seizures, coma, and even cardiovascular collapse.
So it's crucial to recognize the early warning signs and intervene swiftly and decisively.
The first step in managing toxicity is to stop the offending medication immediately. Most adrenergic agonists have relatively short half-lives, so their effects dissipate fairly quickly once the drug is discontinued. Supportive care, such as airway management, oxygen supplementation, and fluid resuscitation, is also essential.
It's like containing the damage, stabilizing the patient, and allowing their body to recover.
And in severe cases, we might need to use medications to counteract the effects of the adrenergic agonists, such as a beta blocker to slow down a racing heart or a vasodilator to lower dangerously high blood pressure. It's like applying the brakes, slowing down that runaway train, and preventing a catastrophic crash.
Now let's shift gears and talk about the crucial nursing considerations for patients taking these medications. As nurses, we're on the front lines administering these medications, monitoring patient responses, and educating patients on their proper use and the potential side effects. It's like equipping them with the knowledge and skills to navigate their healthcare journey safely and effectively.
Nurses play a pivotal role in ensuring the safe and effective use of adrenergic agonists. It starts with a thorough assessment, gathering a comprehensive patient history, including allergies, current medications, and past medical conditions.
It's like building a foundation, laying the groundwork for safe and effective medication management.
And when it comes to adrenergic agonists, we need to pay particular attention to the respiratory, cardiovascular, and renal systems as these systems are most susceptible to the effects of these medications. It's like identifying the potential weak spots, the areas that need extra attention and careful monitoring.
So for instance, in a patient with asthma, we'd be extra vigilant about monitoring their respiratory status, watching for any signs of worsening bronchospasm or other adverse effects.
And in a patient with heart failure, we'd closely monitor their cardiac rhythm and blood pressure, ensuring that the medication is providing the desired benefit without putting undue stress on the heart.
And of course, we'd assess renal function, particularly in patients with pre-existing kidney disease, as some adrenergic agonists can impact kidney function.
It's all about individualized care, tailoring our approach to the specific needs and vulnerabilities of each patient.
And once we've established a baseline assessment, ongoing monitoring is essential, right? It's like keeping a watchful eye, making sure the medication is doing its job and not causing any harm.
Frequent vital sign checks, especially blood pressure and heart rate, are crucial, particularly when administering these medications intravenously. We need to be alert for any any sudden or significant changes that could signal a problem. It's like keeping a finger on the pulse, constantly assessing the patient's response to the medication and adjusting the course as needed.
And we also need to be vigilant for signs of infiltration if the medication is being administered intravenously.
Infiltration, the inadvertent leakage of medication into the surrounding tissues, can occur with any intravenous infusion, but it can be particularly problematic with adrenergic agonists as they can cause vasoconstriction and tissue damage.
So it's like a leak in the pipeline, potentially diverting precious medication away from its intended target and causing harm along the way.
That's why it's crucial to inspect the IV site regularly, looking for any signs of redness, swelling, or pain. And if infiltration is suspected, the infusion must be stopped immediately and the appropriate measures taken to minimize tissue damage.
Now, beyond monitoring, patient education is paramount. As nurses, we play a vital role in empowering our patients, ensuring they understand their medications, their potential side effects, and when to seek medical attention. It's like equipping them with the knowledge and skills to navigate their healthcare journey safely and effectively.
Patient education is indeed a cornerstone of nursing practice. It's about fostering a partnership, ensuring patients are active participants in their care, and feel confident in managing their medications and their health.
And when it comes to adrenergic agonists, patient education is particularly crucial, given the potency of these medications and their potential for side effects.
We need to provide clear and concise instructions on medication administration, emphasizing the importance of adherence to the prescribed dosage and schedule. We need to explain potential side effects, teaching patients how to recognize them and when to seek medical attention. And we need to empower patients to ask questions, to voice their concerns, and to feel comfortable communicating with their healthcare providers.
It's about building trust and fostering open communication, ensuring patients feel heard, understood, and supported throughout their healthcare journey.
Patient education is not just about dispensing information, it's about building a relationship, a partnership based on mutual respect, trust, and a shared commitment to achieving optimal health outcomes.
Now let's talk about some specific examples of patient education related to different classes of adrenergic agonists, starting with bronchodilators, those essential medications for respiratory conditions like asthma and COPD. What are some key points to emphasize in patient education for this group of medications?
When it comes to bronchodilators, patient education should focus on distinguishing between rescue and maintenance medications, ensuring patients understand when to use each type of inhaler. We need to teach proper inhalation technique, ensuring patients are getting the full dose of medication into their lungs, and we need to emphasize the importance of regular use of maintenance medications, even when symptoms are well controlled.
So it's like creating a roadmap, guiding patients through the complexities of their medication regimen, ensuring they understand the different routes, the proper techniques, and the importance of consistency.
And we need to address potential side effects such as tachycardia, tremors, and nervousness, explaining that these are usually mild and transient, but should be reported if they become bothersome or persistent.
And of course, we need to emphasize the importance of avoiding triggers, those environmental factors that can exacerbate respiratory symptoms,
Yeah.
such as smoke, allergens, and cold air. It's like building a fortress, protecting those airways from harm and preventing those acute exacerbations.
Now, moving on to nasal decongestants, another common group of adrenergic agonists, what are some key points to highlight in patient education for this category?
With nasal decongestants, it's crucial to emphasize that they only provide temporary relief from congestion and should not be used for extended periods. We need to explain the risk of rebound congestion, that vicious cycle where overuse leads to more congestion when the medication wears off.
And we need to remind patients that nasal decongestants can interact with other medications, so it's essential to consult with a healthcare provider before using them, especially if they have any underlying health conditions.
And of course, we need to teach proper administration technique, emphasizing that nasal sprays should be used sparingly, with the tip pointed away from the septum to avoid irritation and damage to the delicate nasal tissues.
Now, shifting our focus to ophthalmic adrenergic agonists, those specialized medications used in ophthalmology, what are some key points to emphasize in patient education for this group?
With ophthalmic adrenergic agonists, it's essential to teach proper administration technique, ensuring patients understand how to instill eye drops without contaminating the dropper or touching the eye with the tip. We need to explain potential side effects, such as blurred vision, burning, and stinging, emphasizing that these are usually temporary and resolve on their own.
And we need to remind patients that ophthalmic adrenergic agonists can interact with other medications, including over-the-counter eye drops. So it's crucial to consult with a healthcare provider before using any new eye medications.
And finally, let's talk about patient education for vasoactive adrenergic agonists, those powerful medications used in critical care settings. What are some key points to emphasize in this context?
When it comes to vasoactive adrenergic agonists, patient education is often limited as these medications are typically administered in acute care settings where patients may not be fully alert or able to participate in discussions. However, if the patient is conscious and able to engage, we need to explain the purpose of the medication, its potential benefits, and its potential side effects.
And we need to emphasize the importance of close monitoring, explaining that we'll be checking their vital signs frequently and adjusting the medication dosage as needed to ensure their safety and optimize their response to treatment.
And if the patient is transitioning to home care on a vasoactive adrenergic agonist, we need to provide thorough discharge instructions, ensuring they understand how to administer the medication, recognize potential side effects, and when to seek medical attention.
It's about bridging the gap between the hospital and home, ensuring patients feel supported and equipped to manage their medications and their health in a familiar environment.
Now, let's shift our focus to a crucial aspect of nursing practice: preventing medication errors. Adrenergic agonists, with their potent effects and potential for serious adverse events, require meticulous attention to detail and a commitment to safety at every step.
Medication errors, unfortunately, are a reality in healthcare,
Right.
and they can have devastating consequences, especially when dealing with high alert medications like adrenergic agonists. It's like a delicate dance where every step must be precise and every movement deliberate to avoid missteps.
Preventing medication errors requires a multifaceted approach encompassing clear communication, double-checking orders and dosages, proper labeling and storage of medications, and vigilant monitoring of patient responses.
It's like building a safety net, creating multiple layers of protection to catch those potential errors before they reach the patient.
One common error with adrenergic agonists is confusion between medications with similar names or packaging, such as epinephrine and ephedrine, or norepinephrine and phenylephrine. It's like a case of mistaken identity where a slight resemblance can lead to a grave error.
So it's crucial to pay close attention to the medication name, concentration, and route of administration, verifying every detail before administering the medication.
And when in doubt, always ask for clarification. It's better to err on the side of caution than to risk a potentially harmful medication error.
Another potential pitfall is dosage errors, which can occur due to miscalculations, transcription errors, or incorrect infusion pump settings.
Dosage errors with adrenergic agonists can have significant consequences, as even small deviations from the prescribed dose can lead to significant changes in heart rate, blood pressure, and other vital functions.
So it's crucial to double-check calculations, verify infusion pump settings, and monitor patient responses, closely watching for any signs of overdosage or underdosage.
And if a medication error is suspected, it's crucial to report it immediately, following the established protocols for documentation and incident reporting.
Transparency and accountability are paramount in healthcare, allowing us to learn from mistakes and implement measures to prevent their recurrence.
Medication errors, while often preventable, are a constant threat, requiring unwavering vigilance and a commitment to safety from every member of the healthcare team.
Now, let's shift our focus to a fascinating aspect of adrenergic agonists.
Yeah.
Their role in geriatric patients. As our population ages, we're encountering more and more older adults with multiple comorbidities, often taking a cocktail of medications. And managing adrenergic agonists in this population presents unique challenges.
Geriatric patients often have age-related changes in their physiology, including decreased renal function, altered drug metabolism, and increased sensitivity to certain medications. These changes can impact the pharmacokinetics and pharmacodynamics of adrenergic agonists, making dosing and monitoring particularly challenging.
So it's like navigating a winding road with unexpected turns and potential hazards along the way.
We need to approach medication management in older adults with caution, starting with a thorough assessment of their overall health status, including their cognitive function, their functional capacity, and their social support system.
It's like gathering intelligence, creating a comprehensive picture of the patient's strengths and vulnerabilities, their needs and their resources before embarking on the journey of medication management.
When prescribing adrenergic agonists for older adults, we need to start with lower doses and titrate slowly, monitoring their response closely and adjusting the dose as needed.
It's like finding the sweet spot, that delicate balance between efficacy and safety, minimizing the risk of adverse effects while maximizing therapeutic benefit.
And we need to be particularly mindful of potential drug interactions as older adults are often taking multiple medications for various conditions. It's like conducting an orchestra, ensuring that each instrument plays its part harmoniously without clashing or creating dissonance.
And patient education is even more crucial in this population,
Yeah.
as older adults may have impaired vision, hearing, or cognitive function,
Yeah.
making it challenging to understand and retain information.
We need to tailor our approach to patient education using clear and concise language, large print materials, and multiple teaching methods to ensure comprehension. And we need to involve family members or caregivers in the education process, providing support and reinforcement.
It's about creating a circle of support, ensuring that older adults have the resources and assistance they need to manage their medications safely and effectively.
Now, let's shift our focus to another special population: pregnant and breastfeeding women. The use of adrenergic agonists in these populations requires careful consideration, as these medications can cross the placenta and enter breast milk, potentially affecting the developing fetus or nursing infant.
It's like traversing a delicate bridge where each step must be taken with utmost care, weighing the potential benefits against the potential risks.
The decision to use an adrenergic agonist in a pregnant or breastfeeding woman should not be taken lightly. It requires a careful assessment of the mother's condition, the potential risks to the fetus or infant, and the availability of alternative treatments.
And if an adrenergic agonist is deemed necessary, the lowest effective dose should be used for the shortest duration possible, minimizing exposure to the developing fetus or nursing infant.
And close monitoring of both the mother and the fetus or infant is essential, watching for any signs of adverse effects or complications.
It's about shared responsibility, a collaborative effort between the healthcare provider, the patient, and her family to ensure the safest and most effective course of treatment.
Now, let's shift gears and talk about the fascinating world of adrenergic antagonists, those medications that block the actions of the sympathetic nervous system.
Adrenergic antagonists, also known as sympathetics, are like the opposite of adrenergic agonists, putting the brakes on the sympathetic nervous system, countering its effects and producing a range of therapeutic benefits.
Adrenergic antagonists are valuable tools in managing various conditions, from hypertension and heart failure to anxiety and glaucoma. They work by blocking the binding of catecholamines to adrenergic receptors, preventing the activation of these receptors and inhibiting the downstream effects of the sympathetic nervous system.
So it's like putting a lock on those receptors, preventing the keys, or rather the catecholamines, from unlocking them and triggering those fight or flight responses.
Yeah. Now, let's take a closer look at some of the key players in this category, starting with beta blockers, a widely used class of medications for cardiovascular conditions.
Beta blockers, as their name suggests, block beta adrenergic receptors, primarily beta-1 receptors in the heart. This blockade reduces heart rate, decreases contractility, and lowers blood pressure, making them effective in treating hypertension, angina, and heart failure.
Beta blockers are a cornerstone of cardiovascular therapy, providing a wide range of benefits from reducing the workload on the heart to preventing dangerous heart rhythms.
And they're also used for other conditions such as migraine headaches and anxiety disorders,
Yeah.
highlighting the far-reaching effects of the sympathetic nervous system and the potential of adrenergic antagonists to modulate these effects.
Now, moving on to alpha blockers, another important class of adrenergic antagonists. These medications block alpha adrenergic receptors, primarily alpha-1 receptors in blood vessels and other smooth muscle tissues.
Alpha blockers, by blocking alpha-1 receptors,
Yeah.
relax smooth muscle, leading to vasodilation, of widening of blood vessels, which lowers blood pressure. They're commonly used to treat hypertension, particularly in patients with benign prostatic hyperplasia, or BPH,
Yeah.
as they also relax smooth muscle in the prostate, improving urine flow.
Alpha blockers provide a dual benefit in patients with BPH, lowering blood pressure and alleviating urinary symptoms.
And they're also used for other conditions, such as Raynaud's phenomenon, the
Okay.
condition characterized by spasms of blood vessels in the fingers and toes, causing them to turn white or blue in response to cold or stress.
Now let's shift our focus to a specialized group of adrenergic antagonists, centrally acting alpha-2 agonists. These medications work differently than the alpha blockers we just discussed. They act primarily in the brain, stimulating alpha-2 receptors in the central nervous system, reducing sympathetic outflow and lowering blood pressure.
So it's like sending a calming message to the brain, telling it to dial down the sympathetic nervous system's activity.
Centrally acting alpha-2 agonists are often used in combination with other antihypertensive medications, providing an added layer of blood pressure control.
And they're also used for other conditions such as ADHD and opioid withdrawal, highlighting the diverse applications of adrenergic antagonists.
Now let's take a closer look at some specific examples of adrenergic antagonists and their clinical applications, starting with beta blockers.
The beta blockers, as we've discussed, are a cornerstone of cardiovascular therapy, with a wide range of indications from hypertension and angina to heart failure and arrhythmias. They're like the calming influence, slowing down the heart, reducing its workload, and preventing those erratic heart rhythms.
Beta blockers are a versatile group of medications with different subtypes targeting specific beta receptors, leading to distinct pharmacological profiles and clinical applications.
Can you give us some examples of commonly used beta blockers and their respective clinical niches?
Metoprolol, a beta-1 selective blocker, is commonly used to treat hypertension, angina, and heart failure. It's like a precision tool, targeting those beta-1 receptors in the heart, reducing its workload and preventing those runaway heart rhythms.
And tentenolol, another beta-1 selective blocker, is often preferred in patients with asthma or COPD, as it has minimal effects on beta-2 receptors in the lungs, minimizing the risk of bronchospasm.
It's like navigating a minefield, carefully choosing the right beta blocker to avoid those potential triggers for respiratory complications.
Now, what about propranolol, a non-selective beta blocker that blocks both beta-1 and beta-2 receptors? It's like a broader net, casting a wider influence over those beta receptors.
Propranolol, with its broader blockade, is effective in treating various conditions from hypertension and migraines to essential tremor and performance anxiety. It's like a multi-tool equipped to tackle multiple challenges simultaneously.
And carvedilol, a unique beta blocker with additional alpha-1 blocking properties, is often used in heart failure, providing a combined benefit of reducing heart rate, lowering blood pressure, and improving blood flow to the heart. It's like a synergistic blend, combining forces to optimize cardiac function.
Carvedilol is a valuable option in heart failure, offering a comprehensive approach to managing this complex condition.
Now, let's shift our focus to alpha blockers, those medications that target alpha adrenergic receptors, primarily alpha-1 receptors in blood vessels and other smooth muscle tissues.
Alpha blockers, as we've discussed, relax smooth muscle, leading to vasodilation, a widening of blood vessels, which lowers blood pressure.
Yeah.
They're commonly used to treat hypertension, particularly in patients with BPH, as they also relax smooth muscle in the prostate, improving urine flow.
So they're like dual agents, tackling both hypertension and BPH simultaneously.
Now, can you give us some examples of commonly used alpha blockers and their respective clinical applications?
Terazosin, doxosin, and tamsulosin are commonly used alpha blockers, primarily prescribed for BPH, improving urine flow and reducing urinary symptoms.
And prazosin, another alpha blocker, is often used to treat hypertension, particularly in patients with nightmares or PTSD, as it also blocks alpha-1 receptors in the brain, reducing the intensity of nightmares and flashbacks.
It's fascinating how these medications can target specific receptors in different parts of the body, producing such diverse therapeutic effects.
It is indeed a testament to the complexity and versatility of the sympathetic nervous system and the potential of adrenergic antagonists to modulate its actions.
Yeah, let's touch on centrally acting alpha-2 agonists, those medications that act primarily in the brain, reducing sympathetic outflow and lowering blood pressure.
Clonidine and guanfacine are examples of centrally acting alpha-2 agonists commonly used to treat hypertension, often in combination with other antihypertensive medications. They're like the diplomats, mediating peace between the brain and the cardiovascular system, calming those overactive sympathetic nerves.
And they're also used for other conditions such as ADHD and opioid withdrawal highlighting.
The diverse applications of adrenergic antagonists.
Now let's shift gears and talk about the potential adverse effects and toxicity associated with adrenergic antagonists. These medications, while generally well tolerated, can cause a range of side effects, particularly in older adults or those with underlying health conditions.
It's important to remember that no medication is without risk, and adrenergic antagonists, despite their therapeutic benefits, can have unintended consequences, particularly if not used judiciously.
Understanding the potential adverse effects of these medications is crucial for ensuring patient safety and optimizing treatment outcomes.
Now, can you give us an overview of some of the common side effects associated with different classes of adrenergic antagonists, starting with beta blockers?
Certainly, beta blockers, by blocking beta-adrenergic receptors, can cause a range of side effects, including bradycardia or slow heart rate, fatigue, dizziness, cold extremities, and bronchospasm in susceptible individuals.
So it's like putting the brakes on the sympathetic nervous system a little too hard, slowing down those essential functions and potentially causing discomfort or even harm.
And beta blockers can also mask the symptoms of hypoglycemia or low blood sugar, which can be dangerous in patients with diabetes.
It's like silencing the alarm system, preventing those early warning signs from being heard.
Now, moving on to alpha blockers, those medications that target alpha adrenergic receptors. What are some of the common side effects associated with this class of medications?
Alpha blockers, by blocking alpha-1 receptors, can cause a range of side effects, including orthostatic hypotension or drop in blood pressure upon standing, dizziness, headache, nasal congestion, and reflex tachycardia, a compensatory increase in heart rate in response to the drop in blood pressure.
So it's like a seesaw effect where lowering blood pressure on one side can trigger a compensatory increase in heart rate on the other side.
And finally, what about centrally acting alpha-2 agonists? What are some of the common side effects associated with this group of medications?
Centrally acting alpha-2 agonists by reducing sympathetic outflow from the brain can cause a range of side effects, including drowsiness, dry mouth, constipation, and sexual dysfunction.
It's like calming the mind and body a little too much, slowing down those essential functions and potentially interfering with quality of life.
Indeed. Now, let's talk about toxicity, which can occur with excessive doses or in patients who are particularly sensitive to these medications. The symptoms of toxicity often mirror the adverse effects we just discussed, but they're more pronounced and can quickly escalate, leading to serious complications.
So it's like a slippery slope where those side effects can quickly spiral out of control, becoming dangerous if not recognized and addressed promptly.
Precisely.
Wow.
Now, let's shift gears and delve into the crucial nursing considerations for patients taking adrenergic antagonists. As nurses, we play a pivotal role in ensuring the safe and effective use of these medications. We're the eyes and ears, the hands and hearts, monitoring patient responses, providing education, and advocating for their well-being.
Nurses are the linchpin in medication management, bridging the gap between the prescriber, the pharmacist, and the patient, ensuring that these medications are used judiciously and effectively.
Now, let's delve into some specific nursing considerations for patients taking adrenergic antagonists, starting with beta blockers. What are some key points to emphasize in patient education for this group of medications?
When it comes to beta blockers, patient education should focus on the importance of adherence to the prescribed dosage and schedule, emphasizing that these medications should not be abruptly discontinued without consulting a healthcare provider.
So it's like a steady hand on the helm, maintaining a consistent course, avoiding sudden changes that could disrupt the delicate balance.
We need to explain potential side effects such as bradycardia, fatigue, and dizziness, reassuring patients that these are usually mild and transient, but should be reported if they become bothersome or persistent.
And we need to emphasize the importance of monitoring blood pressure and heart rate regularly, particularly in the early stages of treatment or after any dosage adjustments. It's like keeping a watchful eye on the compass and the speedometer, making sure we're staying on course and maintaining a safe speed.
And we need to remind patients that beta blockers can interact with other medications, including over-the-counter products. So it's essential to consult with a healthcare provider before taking any new medications or supplements.
Now, moving on to alpha blockers, those medications that target alpha adrenergic receptors. What are some key points to highlight in patient education for this category?
With alpha blockers, we need to emphasize the risk of orthostatic hypotension, particularly in the initial stages of treatment or after dosage increases.
So it's like navigating a sudden drop, advising patients to rise slowly from a sitting or lying position to avoid those dizzy spells and potential falls.
And we need to remind patients that alpha blockers can cause dizziness and fatigue. So it's essential to avoid driving or operating machinery until they know how the medication affects them.
And of course, we need to emphasize the importance of regular follow-up appointments to monitor blood pressure and adjust the dosage as needed.
Now, shifting our focus to centrally acting alpha-2 agonists, what are some key points to emphasize in patient education for this group of medications?
With centrally acting alpha-2 agonists, we need to explain potential side effects, such as drowsiness, dry mouth, and constipation, reassuring patients that these are usually mild and tend to improve over time.
We need to advise patients to avoid activities that require alertness, such as driving or operating machinery, until they know how the medication affects them.
And we need to remind patients that these medications can interact with other medications, including alcohol and sedatives. So it's essential to avoid these substances while taking centrally acting alpha-2 agonists.
Now, let's shift gears and talk about a crucial aspect of nursing care, assessing and monitoring patient responses to adrenergic antagonists.
As nurses, we are the front line, the vigilant guardians of patient safety, constantly observing, assessing, and intervening to ensure that these medications are providing the desired therapeutic effects without causing harm.
Monitoring is paramount when it comes to adrenergic antagonists, as these medications can have profound effects on vital functions such as heart rate, blood pressure, and respiratory status.
Now, let's break down the monitoring process, starting with beta blockers. What are some key parameters to monitor in patients taking this group of medications?
When monitoring patients on beta blockers, it's crucial to assess heart rate and rhythm, blood pressure, and respiratory status, particularly in the initial stages of treatment or after dosage adjustments.
So it's like keeping a close watch on the dashboard, making sure all the gauges are reading within the normal range, those vital signs stable and reassuring.
And we need to be alert for any signs of bradycardia, hypotension, or bronchospasm, those warning lights flashing, signaling potential trouble.
And we also need to monitor for signs of heart failure, such as shortness of breath, edema, and fatigue, those subtle clues that the heart may be struggling.
Now, moving on to alpha blockers, what are some key parameters to monitor in patients taking this group of medications?
When monitoring patients on alpha blockers, it's crucial to assess blood pressure, particularly in the initial stages of treatment or after dosage increases. We need to watch for orthostatic hypotension, those sudden drops in blood pressure upon standing that can lead to dizziness and falls.
And we also need to monitor for signs of urinary retention, such as difficulty urinating, a feeling of incomplete emptying, and abdominal distension, particularly in men with BPH.
Now, shifting our focus to centrally acting alpha-2 agonists, what are some key parameters to monitor in patients taking this group of medications?
When monitoring patients on centrally acting alpha-2 agonists, it's crucial to assess blood pressure and heart rate, as these medications can cause both hypotension and bradycardia.
And we also need to monitor for signs of sedation, such as drowsiness, dizziness, and confusion, particularly in older adults or those taking other medications that can cause sedation. It's like dimming the lights too low, making sure they haven't gone out completely.
Indeed, vigilance is key when monitoring patients on these medications, ensuring that they're reaping the benefits without succumbing to the potential side effects.
Now, before we wrap up our deep dive into adrenergic agonists and antagonists,
Yeah.
let's revisit those fascinating critical thinking exercises you mentioned earlier. They're a great way to apply what we've learned and solidify our understanding.
Absolutely. Let's start with exercise number 1. A patient is experiencing a severe anaphylactic reaction after a dose of an antibiotic, and the emergency team is present. The nurse is expecting to give what drug first? Explain your answer.
Okay, so we have a classic emergency situation. Anaphylaxis, a life-threatening allergic reaction that can send the body into a tailspin with plummeting blood pressure, constricted airways, and a cascade of other alarming symptoms. What drug comes to mind immediately?
In this scenario, the nurse would anticipate administering epinephrine first and foremost.
Epinephrine, our trusty friend, always ready to leap into action. But why is it the go-to drug for anaphylaxis?
Epinephrine is a potent, non-selective adrenergic agonist, meaning it stimulates both alpha and beta receptors, making it incredibly effective in countering the cascade of events that occur during anaphylaxis.
So it's like a multi-pronged attack, tackling those allergic reactions from multiple angles.
By stimulating alpha-1 receptors, epinephrine causes vasoconstriction, raising blood pressure. By stimulating beta-1 receptors, it increases heart rate and contractility, supporting circulation. And by stimulating beta-2 receptors, it relaxes bronchial smooth muscle, opening up those constricted airways.
So epinephrine is like a superhero swooping in to save the day, reversing those life-threatening symptoms, and giving the patient a fighting chance.
It's indeed a remarkable medication, a testament to our ability to harness the power of the sympathetic nervous system for therapeutic benefit in emergency situations.
Right, ready for critical thinking exercise number 2.
Absolutely. Let's put our knowledge to the test.
Okay, exercise number 2 is the nurse is assessing a 63-year-old patient who is taking mirabegron or Myrbetriq. Which safety issues are most important to monitor while the patient is taking this medication? Explain your answer.
All right, we're back to mirabegron, our beta-3 agonist friend, for overactive bladder. What safety concerns come to mind in this context?
Well, we know that mirabegron can cause an increase in blood pressure, so monitoring blood pressure regularly is definitely crucial, especially in a 63-year-old patient who might have other underlying health conditions that could be exacerbated by hypertension.
Absolutely. Regular blood pressure monitoring is essential for any patient taking mirabegron, but especially for older adults who might be more sensitive to its effects. Now, what other safety considerations should we be aware of?
Let's think about the mechanism of action. Mirabegron relaxes the detrusor muscle in the bladder, which helps to increase bladder capacity. Could that potentially lead to any problems?
That's an excellent question. While mirabegron is generally well tolerated, there is a potential for urinary retention in some patients, especially those with pre-existing bladder outlet obstruction.
So it's important to assess for any signs of urinary retention, such as difficulty urinating, a feeling of incomplete emptying or abdominal distension.
Precisely. If urinary retention is suspected, it's crucial to notify the healthcare provider promptly so they can adjust the treatment plan as needed.
Excellent point. So in summary, the most important safety issues to monitor in a patient taking mirabegron include blood pressure and signs of urinary retention.
Exactly. And as always, thorough patient education is paramount. We need to empower our patients to be active participants in their care, teaching them how to monitor for these potential side effects and when to seek medical attention.
Now, to wrap up our deep dive, let's explore those review questions you mentioned earlier. They're a great way to test our knowledge and ensure we've grasped the key concepts.
Let's begin with question number 1. The nurse caring for a patient who is receiving beta-1 agonist drug therapy needs to be aware that these drugs cause which effect. Select all that apply.
Okay, so we're talking about beta-1 agonists, those medications that primarily act on the heart, mimicking the effects of epinephrine and norepinephrine. The options are A, increased cardiac contractility, B, mydriasis, C, increased heart rate, D, vasoconstriction, E, increased GI tract motility.
So which of these effects would we expect to see in a patient receiving a beta-1 agonist?
Well, knowing that beta-1 agonists stimulate the heart, I'd say that A, increased cardiac contractility, and C, increased heart rate are definitely correct. Beta-1 agonists increase the force of contraction and the rate of the heart, those two key parameters of cardiac function.
Excellent. You've grasped the fundamental actions of beta-1 agonists. Now, what about the other options?
I don't think beta-1 agonists directly affect the pupils, so B, mydriasis is probably incorrect.
That's correct. Mydriasis, or dilation of the pupils, is primarily caused by alpha-1 agonists, not beta-1 agonists.
Now, D, vasoconstriction is tricky. I know that some adrenergic agonists cause vasoconstriction, but I'm not sure if it's a direct effect of beta-1 agonists.
You're right to be cautious. While some adrenergic agonists can indirectly cause vasoconstriction, it's not a a primary effect of beta-1 agonists. Vasoconstriction is mainly mediated by alpha-1 receptors, not beta-1 receptors.
Okay, so D is out. What about E, increased GI tract motility?
That one is also incorrect. Beta-1 agonists don't directly affect the gastrointestinal tract. In fact, adrenergic agonists in general tend to decrease GI motility, not increase it as part of the fight or flight response, diverting blood flow away from the digestive system and towards the heart, lungs, and muscles.
So the correct answers for question 1 are A, increased cardiac contractility, and C, increased heart rate.
Exactly. You've nailed it. Now let's move on to question number 2. During a teaching session for a patient who is receiving inhaled salmeterol, the nurse emphasizes that the drug is indicated for which condition?
Okay, so we're talking about salmeterol, a long-acting beta-2 agonist, commonly used in the management of respiratory conditions.
Yeah.
The options are A, rescue treatment of acute bronchospasms,
Yeah.
B, prevention of bronchospasms, C, reduction of airway inflammation, D, long-term treatment of sinus congestion.
So what is the primary indication for salmeterol?
Well, I know that salmeterol is a long-acting bronchodilator, so it's not used for rescue treatment of acute attacks.
Yeah.
So A is out. And while salmeterol can help reduce airway inflammation indirectly by preventing bronchospasms, it's not its primary mechanism of action. So C is probably not the best answer.
Excellent reasoning. You're thinking critically and eliminating those less likely options.
And D, long-term treatment of sinus congestion is definitely incorrect. Salmeterol is a bronchodilator, not a nasal decongestant. It targets those beta-2 receptors in the lungs, not the blood vessels in the nasal passages.
Precisely. You've narrowed it down to the most likely option. So that leaves us with B, prevention of bronchospasms. What do you think?
I think that's the correct answer. Salmeterol is a long-acting bronchodilator used for long-term control and prevention of bronchospasms in conditions like asthma and COPD. It's like a visual guardian, keeping those airways open and preventing those sudden frightening episodes of breathlessness.
You are absolutely correct. Salmeterol is not a rescue inhaler. It's taken regularly to prevent bronchospasms from occurring. It's a cornerstone of maintenance therapy, a preventative measure, not a reactive one.
2 for 2. This is exhilarating. Now, let's conquer question number 3. For a patient receiving a vasoactive drug, such as intravenous dopamine, which action by the nurse is most appropriate?
Okay, let's delve into the realm of vasoactive medications, those powerful agents that influence heart rate, blood pressure, and blood flow distribution. The options are A, monitor the gravity drip infusion closely and adjust as needed. B, assess the patient's cardiac function by checking the radial pulse. C, assess the intravenous site hourly for possible infiltration. D, administer the drug by intravenous boluses according to the patient's blood pressure.
Well, A, monitor the gravity drip infusion closely and adjust as needed doesn't sound quite right. We typically use infusion pumps to administer vasoactive drugs like dopamine, not gravity drips. Precision is key with these potent medications, and infusion pumps provide that level of control and accuracy that gravity drips simply can't match.
You are absolutely right. Infusion pumps are the standard of care for administering vasoactive medications, ensuring precise delivery and minimizing the risk of dosage errors.
Yeah. Yet, assess the patient's cardiac function by checking the radial pulse is important, but I don't think it's the most crucial action in this scenario. While assessing the patient's cardiac function is essential, there's a more immediate concern when administering intravenous dopamine.
You're thinking critically, prioritizing those actions that are most vital in this particular context.
Now, D, administer the drug by intravenous boluses according to the patient's blood pressure sounds downright dangerous. We never administer vasoactive drugs like dopamine by intravenous bolus. It's far too risky with the potential for rapid and unpredictable fluctuations of blood pressure and heart rate. They need to be given as a continuous infusion and carefully titrated based on the patient's response, those incremental adjustments ensuring a smoother and safer course.
Absolutely. Intravenous boluses of vasoactive medications are generally avoided due to the risk of abrupt and potentially dangerous hemodynamic changes. Continuous infusion with careful titration allows for more controlled and predictable adjustments.
That leaves us with assess the intravenous site hourly for possible infiltration. What do you think?
You are absolutely correct. Assessing the 5E site for infiltration is crucial when administering vasoactive adrenergic agonists like like dopamine. Remember, these drugs can cause vasoconstriction and tissue damage if they leak out of the vein and into the surrounding tissue. It's like a breach in the levee, those potent medications seeping into those delicate tissues, causing harm and disrupting blood flow.
I'm glad I remember that from our earlier discussion. It highlights the importance of vigilance, that constant awareness of potential complications and those subtle clues that something might be amiss. So the correct answer for question 3 is C, assess the intravenous site hourly for possible infiltration.
Precisely. You're on a roll, demonstrating a keen understanding of the nuances of vasoactive medication administration.
Okay, let's tackle question number 4. A patient is receiving dobutamine for shock and is complaining of feeling more skipping beats than yesterday. What will the nurse do next?
Okay, we have a patient receiving dobutamine, a beta-1 agonist used to improve cardiac output in shock. That precarious state where the body's circulation is compromised, those vital organs starved of oxygen-rich blood. The patient is reporting palpitations, that unsettling sensation of a racing or irregular heartbeat, a red flag that warrants further investigation. The options are A, monitor for other signs of therapeutic response to the drug. B, titrate the drug to a higher dose to reduce the palpitations. C, discontinue the dobutamine immediately. D, assess the patient's vital signs and cardiac rhythm.
Well, A, monitor for other signs of a therapeutic response to the drug doesn't seem like the right course of action here. The patient is experiencing a new symptom, a potential sign of an adverse effect, and we need to investigate further, not just passively observe.
You are right to be cautious. We shouldn't ignore new symptoms, especially when dealing with powerful medications that can have significant effects on the cardiovascular system.
Now, B, titrate the drug to a higher dose to reduce the palpitations sounds downright dangerous. Increasing the dose of a beta-1 agonist in a patient experiencing palpitations could worsen the problem and potentially lead to dangerous heart rhythm abnormalities.
Yeah.
It's like adding fuel to the fire, potentially pushing the heart into a chaotic and unsustainable rhythm.
Absolutely. We never want to blindly increase the dose of a medication without first assessing the situation thoroughly, gathering all the necessary information before making any adjustments.
And C, discontinue the dobutamine immediately seems a bit extreme. The patient is in shock, a life-threatening condition, and relies on the medication to support their cardiac function. Abruptly discontinuing the medication could have dire consequences, potentially plunging the patient into an even more precarious state.
You are right to be cautious. Discontinuing the dobutamine abruptly could be detrimental, especially since the patient is in shock and relies on the medication to support their cardiac function. It's like pulling the rug out from under them, removing that crucial support that's keeping them afloat.
That makes sense. We need to weigh the potential benefits against the potential risks, making those calculated decisions that prioritize patient safety and well-being. So we're left with assess the patient's vital signs and cardiac rhythm. What do you think?
That is the most appropriate action. We need to gather more information before making any decisions about the dobutamine infusion. Assessing the patient's vital signs, including their heart rate and blood pressure, and evaluating their cardiac rhythm using an electrocardiogram or ECG will give us a clearer picture of what's going on.
So it's all about gathering data, those vital clues, and then making an informed decision based on the evidence.
Precisely. Based on the assessment findings, the healthcare team can then determine the best course of action, whether it's adjusting the dose of dobutamine, adding another medication, or perhaps even considering a different treatment strategy altogether. It's like a detective piecing together the clues, following those leads, and ultimately arriving at the truth, the most appropriate course of action.
I'm starting to see a pattern here. With these potent medications, careful assessment and monitoring are paramount.
Yeah.
You can't just set it and forget it. We need to be actively involved in our patients' care, constantly evaluating their response to treatment and making adjustments as needed. Those fine-tuning adjustments that optimize their care and ensure their safety.
Absolutely. Vigilance, critical thinking, and a deep understanding of these medications are essential for providing safe and effective care to our patients. It's a constant process of observation, assessment, and intervention, a dynamic dance between knowledge and action, a commitment to excellence in nursing practice.
Well, I think we've covered all the bases today. We've delved deep into the fascinating world of adrenergic agonists and antagonists, exploring their mechanisms of action, their diverse clinical applications, their potential adverse effects, and those crucial nursing considerations that guide our practice and ensure patient safety.
It's been an enriching journey, a deep dive into the complexities of these medications and their impact on patient care.
And remember, learning is a lifelong endeavor, a continuous process of exploration and discovery. We encourage you to continue seeking knowledge, asking questions, and challenging yourself to delve deeper into the medications you administer.
Your dedication to excellence in nursing practice makes
Yeah.
a real difference in the lives of your patients, ensuring their safety, promoting their well-being, and empowering them on their journey towards optimal health.
And a heartfelt thank you to our listeners for joining us on the deep dive.
Yeah.
Your curiosity and your commitment to lifelong learning inspire us. Until next time, stay curious and keep diving.